Good evening and thank you all for joining us today. On behalf of Nari and Femborn Division of Jagsonpal Pharma, we welcome you all to the General Club today. Up to date with updates, organized by the Haryana chapter of ISAR. Today's article is on frozen embryo transfer. We present to you Cystelia M, formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Rivatrone SR 20 mg micronized and sustained release tablet of Progesterone to improve compliance and enhance outcome. Rivatrone 10 mg tablets are also available. Another we have Lycored M, tablets of natural lycopene fortified with N-acetylcysteine enriched with coenzyme Q10 and L-carnitine. For added advantage, we have Lycored M, which contains two proprietary complexes. First is natural lycopeneous lycobeads from Israel and L-carnitine and L-tartaric acid in ratio of 2:1 to give highest available L-carnitine as Carnipure sourced from Switzerland. So again, a warm and hearty welcome to all the esteemed faculties and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. So to refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now, I invite Dr. Jyoti Malik, Chairperson, Haryana Chapter ISAR and Director Roots IVF at JJ Institute of Medical Services, Bahadurgarh, to kindly initiate the program. Over to you, ma'am.
Thank you, Jagsonpal, and welcome all on this platform today on Up to Date with Updates, episode 13. And as the chairperson of Haryana ISAR, I feel proud that we are continuing with this academic activity every month. And with the help of Jagsonpal, we are doing these journal clubs. And we have actually, with the blessings of our think tanks of ISAR, with Dr. Ameet Patki, sir. Can I have sir's CV, please? Sir is the Medical Director, Fertility Associates of Khar, Hinduja and Surya Hospitals, Khar, Mumbai. And sir is the National President of our ISAR. And he is a constant support to all the activities that we hold in our regional chapters under his guidance. Then thank you so much also to Dr. Asha Bakshi ma'am, who is the Honorary Secretary General and is the lead consultant at Asha Bakshi Fertility Center. And ma'am also is always at the heck of a call away and always giving us great ideas to promote our chapter. And also we have today, along with the other think tanks, Dr. Sunita Tendulkar ma'am, who is the president-elect, the immediate past president, Dr. Nandita ma'am, the vice president, Dr. Madhuri Patil and Dr. Sujata Kar, and our chairpersons for embryology, Dr. Charudat, and vice chairman, embryology, Dr. Keshav. So these are our think tanks. They're always giving us, are always there for such activities. And with my team, ISAR, with the secretary, Dr. Meenu, clinical secretary, Dr. Manju, and treasurer, Dr. Lakshmi, we feel blessed to be a team together presenting such activities. So today we have a special guest who would be sort of expert today for our presentation. And she is none other than Dr. Pooja Mehta from, she graduated and trained in field of ART and endoscopy from Foxy, Mumbai. And she is presently the chairperson of the Chandigarh chapter of ISAR. Since 2009, she has been the head of department of the Fortis Bloom IVF Mohali under the special guidance of Dr. Nandita Palshetkar and Dr. Rishikesh Pai sir. And today our presenter is a young, dynamic, very active Dr. Shivangi Sharma, who is Associate IVF Consultant at Cloudnine, Faridabad. And she has many awards and recognitions, and she has also received an appreciation prize for her paper presentation in the AOGD Delhi conference, and All India rank 51 on the fellowship entrance test. And she is a bright presenter as well. She has presented in the past also in this platform. And today, our topic is also something which is though we I mean that is that we would be discussing. So over to Dr. Shivangi and Dr. Pooja, so we can start with our journal club discussions. Thank you so much.
Thank you so much, Dr. Jyoti, and thank you, ISAR, for having me today. Actually, I think this young dynamic girl is really going to talk to us about some topic which is really of interest, because all of us are shifting to single embryo transfers nowadays. And of course, natural, modified natural or natural cycle IVF, all of us are doing nowadays. So I think she's going to put a light on all these aspects. So over to you, Shivangi.
Very good afternoon, ma'am. Thank you so much, Jyoti ma'am, and thank you so much, Pooja ma'am, for such a warm introduction. I would also like to thank ISAR Haryana for giving me this opportunity to present in front of such esteemed audience. So, very good afternoon, everyone. So today I'll be discussing about the article which is taken from Fertility Sterility Journal, and the title goes as Impact of Follicle Size Before Luteal Progesterone Supplementation on Clinical Outcomes of Modified Natural Single Frozen Embryo Transfer Cycle. The author for the article is Kevosi et al. So as we all know, there's a growing trend towards the use of natural cycles and modified natural cycles as effective protocols for frozen embryo transfer. And this is so as to minimize the use of medications and essentially eliminating the follicular phase endometrial preparation with exogenous estradiol, which we all know has been known to come with some side effects in the pregnancy. Natural cycle FET and modified natural cycle FET protocols involve several follicular scans as well as endocrine system serum testing with the goal of measuring a thick endometrial lining as well as a large follicle before the LH surge or the HCG trigger to time the upcoming embryo thaw and transfer. Previous publications have also indicated that along with the endometrial thickness of more than 7 millimeter, natural follicular growth is monitored until a dominant follicle reaches 16 to 18 millimeter in diameter before the SCG trigger LH surge is given in the preparation for potential luteal progesterone supplementation with progesterone before the actual FET. So this diagram will give us an idea about the various preparations that are available. The first one is the HRT cycle, that is a hormone replacement therapy cycle, in which the patient is called on the second day of cycle. And after that, she started on exogenous estrogen. And once the desired endometrial thickness is achieved, we start with the progesterone. In opposed to this, we have broadly three types of natural cycle. The first one is a pure natural cycle, in which we don't do anything externally. We just monitor the cycle with serum LH and P4 measurements as well as ultrasound monitoring. And as soon as we see a rise in LH and P4, that is, it signifies that the LH surge has started. That time we start progesterone and we plan the embryo transfer accordingly. But it is very cumbersome because again we have to do serial HP4 measurement, and along with that the timing of the transfer can be a bit cumbersome in these pure natural cycles. So some modifications came up. So one of them is a commonly used modified natural cycle, in which similar to the natural cycle, pure natural cycle, we start with the ultrasound monitoring and we monitor the dominant follicles serially up to a diameter of 17 millimeter. And when the size is reached, we trigger the patient with recombinant HCG. And in the progesterone is started around 48 hours after we give the HCG shot. It basically helps us to time the FET more effectively. And the third one is the stimulated cycle in the natural cycle, in which we can also give patients some stimulation with anti-estrogen or aromatase inhibitor so as to help the follicle grow. And as soon as the follicle reaches more than 17 millimeter, we give the recombinant HCG and plan the transfer accordingly. So with this background, we move to the aim of our study, which is to determine whether the follicular size at the mid-cycle and or other clinical and embryological factors are predictive of modified natural cycle single frozen embryo transfer outcomes. So the why is this aim of the study so important? Because if the follicle size before the luteal phase progesterone supplementation in combination with the thick endometrial lining does not impact the out of the cycles, then the need of the multiple ultrasounds will be omitted and even the need for the endocrine testing would be minimized. Coming on to the materials and methods, in a present study, a retrospective chart review was performed of all the FET cycles that were performed between January 1st, 2018 to April 1st, 2024 at Austin Fertility and Reproductive Medicine, Westlake IVF. After an inclusion and exclusion criteria were applied, clinical and embryology information were abstracted from the modified natural cycle FET cycles, and the total number of patients that were totally enrolled were 115. So the inclusion criteria of the study was all the nominally ovulatory female subjects between the ages of 18 to 45 years who had undergone IVF with autologous oocytes for embryo formation and single FETs with untested or trophoectoderm testis euploid blastocysts for subjects who were less than 35 years of age at the time of egg retrieval. But however, the age was more than 35, it has to be a trophoectoderm tested euploid blastocyst. The exclusion criteria were donor oocytes, donor embryos, patients who have undergone double embryo transfers, gestational carrier cases, or in which the trophoectoderm tested biopsy showed aneuploidy or mosaic embryos, and in cases where the MNFET cycles were performed using the hormonal medication or ovulation induction agents for the endometrial preparation. So broadly, the patients were divided into two groups. One was group A, which consists of women who underwent modified natural cycle single FET with lead follicle size of millimeter on the day of trigger or peak present on the ovulation predictor kit. The total number of patients enrolled on this group was 50. Group B consisted of women who underwent modified natural cycle with lead follicle size of more than 16 millimeter on the day of trigger or if the peak was present on the ovulation predictor kit. And in this group, we have total 65 patients. So for all these patients, the patient underwent modified natural cycle with cycle date 10, 11, 12 that was chosen for the initial monitoring with the TVS, as well as the very same day, the serum E2 and progesterone level were also tested with the plan for giving the recombinant HCG, that is the ovidual trigger, at the time when the embryo, the endometrial thickness reached more than 7 millimeter and when the progesterone level was less than 3 nanogram per ml, regardless of the lead follicle size. Subsequent visit for TVS and serum endocrine testing was needed only if the aforementioned endometrial criteria were not met on these respective mentioned dates. Luteal phase supplementation with either progesterone in oil intramuscular injection at a dose of 50 milligram once daily or with endometrin 100 milligram vaginal inserts 3 times a day was started on the morning after peak LH surge or approximately 36 hours after nighttime HCG injection. And for all the patients, single frozen embryo transfer was performed via abdominal ultrasound guidance with a 23 centimeter Wallace ET catheter. Good quality blastocysts were considered to be those who are of a grade 2 BB or higher in accordance with the Gardner and Schoolcraft grading system for the blastocyst. A serum quantitative HCG level was checked on 9 to 10 days after the embryo transfer, and if the HCG level was positive, a second quantitative HCG level was performed 2 days later to assess a trend in the level. In cases of reassuring HCG level, TVS was performed between 6 to 7 weeks of gestation to evaluate the gestational sac, yolk sac, fetal pool, and fetal cardiac motion. So coming on to the outcomes of study, there were broadly two types. The first was the primary outcome, which was the ongoing pregnancy rate, which was defined as the number of ongoing pregnancies divided by the number of embryo transfers per group. And the secondary outcomes were the implantation rate, which was defined as number of gestational sacs visible on the TVS between 6 to 7 weeks of gestation, divided by the total number of embryo transfers per group. Clinical pregnancy rate was defined as the number of gestational sac visible at TVS between 6 to 7 weeks with fetal pool and cardiac motion divided by the total number of embryo transfer per group. And the third secondary outcome was the spontaneous abortion rate, which was the number of pregnant patients who experienced miscarriage before 20 weeks of gestation divided by the total number of pregnancies in each group. Statistical analysis was performed with the t-test for mean of continuous variables, and Pearson chi-square test was used for the categorical variables. Logistic regression model was used to conduct 8 multivariate analysis to examine the relationship between lead follicle size and 4 critical outcomes that were the ongoing pregnancy rate, implantation rate, clinical pregnancy rate, and spontaneous abortion rate. Lead follicle size was used twice in each analysis and in 2 different ways. The first was in a binary variable, where the participants were divided into 2 groups. Group A was when the lead follicle size is less than 16 millimeter, and group B with the lead follicle size of 16 millimeter, more than 16 millimeter, as we have discussed. And the other type by which we used it was a continuous variable. And all the p-values which were less than 0.05 were considered statistically significant. Coming on to the results of the study. So this table shows the group characteristics and the pregnancy outcomes in the two group. And as we can see, the two groups had similar characteristics like female age, parity, AMH level, progesterone injection, oil-based progesterone injection, endometrial vaginal inserts. Even the trigger and LH surge was similar in both the groups. Along with this, the endometrial thickness, the number of embryo which underwent PGTA, and also the number of embryos which were non-PGTA tested was same in both the groups. However, the groups differed in terms of the BMI, lead follicle size, mid-cycle E2, and mid-cycle progesterone. And as we can see that the group B had significantly higher BMI, also a significantly higher lead follicle size, and higher E2 and progesterone levels. But the important thing is, despite of these things, the ongoing pregnancy rate, implantation rate, miscarriage rate, and clinical pregnancy rate was similar in both the groups. This table shows a descriptive analysis of the cause of infertility in the two groups. For the cause of infertility, only a descriptive analysis is being done because the sample size was too short for any multivariate logistic analysis to be done. So as we can see, in both the groups, there were people, mostly the people had multiple factors which caused them infertility. But however, one thing that was significantly higher in the group 2 was the male factor, which was significantly higher as compared to the group A. Other than that, the causes were diminished ovarian reserve, endometriosis, tubal factor, uterine and unexplained factor, and recurrent pregnancy loss factors, which were almost similar in both the groups. So as we have discussed that the BMI, E2 level and the progesterone level between groups A and B varied significantly. Now, so as to know whether these three variables have confounded our results, a multivariate analysis was conducted to investigate it. So if we see in this table, this is a logistic regression analysis of the factors. So all the factors that are considered are mentioned on the left side. And suppose we have the basic outcome that we need to measure was whether a follicle size of more than 16 millimeter gave us any positive or important lead in terms of the pregnancy rates. So as we can see, for the lead follicle size also, all the values are mostly in the negative. It means even in the logistic regression analysis, the follicle size did not play a significant role in determining the outcomes of the embryo transfer that we were doing. Also, along with it, the p-value was non-significant for all of these parameters. Hence, from this table, we can conclude that the lead follicle size does not play a significant role in determining the modified natural cycle FET outcomes in the patient population. And the previous chart that we saw, it was when we were taking the follicle size as a binary variable, that is less than 16 millimeter or more than 16 millimeter. This other table is if we are considering the follicle size as a continuous variable. Even with this as the point, the follicle size did not impact the outcomes in terms of ongoing pregnancy rate, implantation rate, clinical pregnancy rate, or spontaneous abortion rates. So coming on to the discussion, so there are some of the studies that were done and had similar aim of the study. So the one study that was done by Carlos et al. In 2023, they found in the study that in these patients, HCG can be administered between a follicular size of 13 to 22 millimeter if there are adequate endometrial characteristics and if the progesterone is less than 1.5 nanogram per ml, which also is in accordance with the results of this study that the size does not matter. But however, Carlos specified that the size range was 13 to 22 millimeter. Another study, which was in contrast to our study, was done by Manan et al. That was done in 2024. And they basically compared whether it is feasible to give the trigger at less than 18 to 20 millimeter and still get a good results. The main aim for them was whether we can avoid holiday embryo transfer by just preponing the trigger a little bit from 18 to 20 millimeter to 16 to 17 millimeter. And in their study, they found that trigger can be given when the follicle is around 16 to 17 also. But however, they did not take into consideration the size that were less than 16 millimeter into their study. Another important concept that strengthens our finding of the studies was the study done by Jeppesen et al. In 2012, where they mentioned that LH-HCG receptor expression is an important component of the LH surge that is there. And for that, the receptor expression must be there on the follicle. They said that this expression can be observed in the follicle, which is as small as 3 millimeter also, with higher expression is noted when the diameter is more than 10 millimeter. And hence, even at these sizes, the follicle is capable of ovulating and even ultimately producing the corpus luteum. So this finding or this explanation actually fits into the results of the study also, that maybe because even if the size of the trigger is less than 16 but since it is more than 10 millimeter in the size, it is still capable of ovulating and producing corpus luteum. Maybe that is one of the reasons it is not impacting the pregnancy outcome in our case. Another study that was done, which supports our results, were done by Godini et al. In 2021, where they basically did a progesterone programmed frozen embryo transfer cycle, in which as soon as the follicle size reached 14 millimeter, from the very next day they started progesterone supplementation. And in this study, they actually found a higher live birth in patient in which the trigger was given or the progesterone was started at a size of more than 14 millimeter or above. So coming on to the strengths of our study, the first one is that only the frozen embryo transfer with single blastocyst as well as vitrified thaw blastocysts were included. So there was no confusion because of two embryos being transferred and we are not sure about the results. And the second important strength was the modified natural cycles that were included were relatively homogeneous as cycles with endometrial preparation via exogenous hormonal ovulation induction agents being excluded from it. However, the study also has some limitation, the most important being because of the retrospective nature of the study. Along with that, the small sample size of 115 only included by combining both the groups. Along with this, important thing was only the cycles with HCG trigger were included. They did not include the cycles in which the HCG trigger was not given and the progesterone was started from the very next day. So maybe the positive pregnancy outcomes that we are seeing, even with less size of the follicle, could be because of the HCG trigger also, which also provides an inherent LH component to it. Other than that, the cycle which includes the ovulation induction agents, which is very commonly used even in the patient with irregular cycles for performing the modified natural cycles, were excluded. So we cannot extrapolate these results to those patients. Along with this, since in this study the luteal phase support was given, the reason for no effect on the pregnancy outcome in this study can be due to in the fact that the role of corpus luteum was already taken care of by the progesterone that we have started in the patients. So coming on to the conclusion of the study, it said that in the normal ovulatory woman undergoing modified natural single embryo transfer with natural endometrial preparation and use of either HCG trigger or LH surge to time the FET, lead follicle size before luteal phase progesterone supplementation does not seem to impact the clinical outcomes such as implantation rate, clinical pregnancy rate, spontaneous abortion rate, or ongoing pregnancy rate. Thank you.
I think, Dr. Shivangi, this is the excellent presentation which you've given. You've actually given all the pros and cons of the study. And since your comparison is there, that is very nice with all the 4 studies which you have shown, that comparison. That was very nice. So coming back to like what message do we pass on to the people? I mean, what message are we passing on that we actually have to rely on our tests and our ultrasound and maybe our clinical judgment before going ahead for a transfer, because for us, when a patient comes to us for a embryo transfer, they want a positive outcome. So this method I think would not be of great help, but then definitely yes, we all are doing a lot of modified natural cycles And in fact, stimulated natural cycles, in my personal experience, I'm getting quite a good response. What is your experience with that, Shivani?
Same, ma'am. Actually, most of the patients, we also used to give letrozole in the starting, and we used to do the normal follicular study, per se,
Huh.
and the hormonal evaluation we used to do on the day of before giving the trigger.
Exactly.
Yes, ma'am. E2LHP4.
And have you observed, Dr. Shivangi, that what happens normally is at times, say if we give trigger when the progesterone level is less than 1.5, there you mentioned somewhere that it was given before the progesterone level was less than 3. In one of the, I mean, they waited till it was less than 3. They were like, they included that also, like more than 1.5.
Yes, ma'am. In one place they have mentioned, 1.5 they have mentioned in the materials and methods, ma'am. But yes,
Yeah.
there are many studies in which they have waited up till the progesterone levels were more than 3.
Around 3, yeah,
Yes,
less than
ma'am.
3. That's
Yes,
more
ma'am.
than 1.5.
More than
So
1.5.
actually, we normally, I to cancel my patient if the patient progesterone level is more than 1.5. But have you observed that the next day, normally we start the progesterone from 36 hours or say 48 hours after the trigger.
Yes,
But
ma'am.
I have in my practice observed, I did a progesterone, but I did not do any study for it. On the next day of the trigger, I did progesterone level, and then I saw that the progesterone was naturally also increasing
Yes, ma'am.
as soon as I gave the trigger. So the progesterone was naturally also increasing. So in fact, in a few patients, I did for day 5 embryo transfer. I gave progesterone on the day immediately next to the trigger, and I gave progesterone for 6 days, and then did the transfer, and I got a good outcome in those patients. Maybe we'll have to do some study on this. And in fact, I think we have to increase the sample size for all these things, like
Yes, ma'am.
should be a multi-centric kind of a trigger. So our exercise has to be there where we actually do our old things where we are doing proper modified cycle, we are doing progesterone level, estrogen level, and then going ahead for a transfer. Any questions from the participants or audience?
Hi, Dr. Pooja, and hi, Shivangi.
Hello, ma'am.
Hi, sorry, I had to connect a little late. Very nice presentation. I also had the same doubt as Dr. Pooja. So, Shivangi, in one of the studies, the exclusion criteria, they mentioned that they have taken progesterone as less than 3 nanograms. That means more than 1.5 also they have is included in the study, isn't it?
Yes, ma'am. In some of the studies they have included, ma'am.
But is there some basis for that? I mean, I'm just asking, is there some basis for that? I mean, why are they have included that?
Actually, in most, sorry, ma'am.
No, I was just, yeah, I was also inquisitive that because more than 1.5, our pregnancy rates are going to dip down. So that is what I wanted to understand, that how they have continued with that.
Actually, one or few studies that I read, ma'am, was in those patients, they have taken progesterone level at 2 point of time. One is on the second day. In that case, if on the second day it is coming between, if it is less than 1.5 on the second day, that they are taking as the initiation part. But if it is done before the triggering, in that day, some people are taking 3 as the cutoff for progesterone. But again, it varies from author to author what is the practice in their center. But it is mostly in the European studies that I have found that.
Minu, I feel they must have done it for some study purposes only, Like, I don't think so. We can give this take home message that progesterone more than 1.5 is of any use, We should actually be canceling the cycles because maybe they have done it for some study purpose. Otherwise, any basis, so it's very difficult to identify a basis for that.
Yeah, and another thing is that, it is also because in certain studies, they have also mentioned that the cutoff is different for when you're doing a fresh transfers and for a IVF cycle vis-a-vis for ovulatory embryo transfer cycles. That is the time the cutoff would be taken as 3. Dr. Jyoti, are you there? Any comments from your side?
I think Jyoti is into cesarean, right now she has
Okay.
emergency. She had to leave up Jyoti, I believe.
Okay.
So that's why.
Right.
So I think this Dr. Shivangi is an excellent orator. She's like penned down everything very well, and she's presented all very well, So
So basically, Shivangi, can you just, I mean, so for take home, what are you, what is the summarization that there is no cutoff for the cyst size?
Yes, ma'am. For the dominant follicle size
Follicle size.
that they have to
Hmm.
study, ma'am.
But then in your practice, Meenu, are you doing, I mean, when are you giving the trigger around 18 millimeters? Or you're doing progesterone for all the patients who are doing, modified or
See,
natural cycle?
for not for all the patients, but yes, it's more of a clinical judgment where even at 7 millimeters, more than 7 millimeters of lining with a good flow is what we are focusing on. And yes, if the cyst size, sorry, you're muted, Dr. Pooja. Dr. Pooja, you have muted yourself. Yeah. And the size, anything more than 16 millimeters is our cutoff that we are taking. And yeah.
Have you seen that there is a lot of sometimes asynchronous between the follicle size and the endometrial lining at times? Have you seen that?
Yeah, at times it is there. At times it is there. But then with the addition of any ecosprin and the antioxidants, RG prime, I mean, it does make a difference that it will increase.
See,
But
I mean, my question was because I feel that sometimes we feel that the endometrium is already ready, but the follicle is not yet ready. So what do you do
yes.
in those patients? I feel at times that we've seen because especially in stimulated cycle, at times, that if the follicle is only 13, 14 millimeters, so I think at 14 millimeters also we can give the
You
trigger.
can.
Yeah.
Yeah.
So that at
I
least that
think that would also be, that is a time when routinely they can do the blood test. That's where the P4 will also make a difference.
yes,
Yes.
definitely. Okay.
Yeah.
Anyways.
I think, Dr. Shivangi, it's been a pleasure and thank you for updating us. And this was a very, very relevant topic and a very clinical. We're trying to bring out all the clinical topics as simple as it looks, but we feel that it is very important for the discussion. And so thank you, Dr. Shivangi, for this. And thank you, Dr. Pooja, for being the expert for this session. And it's always lovely to have you on board. And we look forward for many more webinars as an expert with us. So thank you so much. And thank you, Dr. Deepika, I think Jagsonpal, for giving us the always the support that we have for the webinars. And
As I was saying, I would to like thank you everyone for their immense knowledge and discussion about the article. And thank you participants for joining in today. So the session was brought to you by Jagsonpal Nari Division, makers of Cysteria M, Rivatron SR, Lycored M, and My Sakhi, a CSR activity which we have, which is initiated by Jagsonpal. And along with that, again, I would like to thank everyone for joining the session and have a great day, everyone.
Thank you so
thank you so much. Thank you, Dr. Pooja, Dr. Shivangi. Thank you.
Thank you, ma'am. Thank you, ma'am. Take care, ma'am.